to be speaking to you today on the transition of care from pediatrics to adults. So we'll review the importance of a successful transition to an adult provider. We'll discuss some unique aspects of pediatric narcolepsy, and we'll discuss some ways to maximize the success of children with narcolepsy. So why is this important? It's important to talk about the transition of children with narcolepsy from pediatrics to adults, because we really do want to be diagnosing these children when their symptoms are starting, which is often in childhood. We've talked a lot about how this diagnosis can be misdiagnosed, and many individuals who are diagnosed in early adulthood can trace symptoms back 10 years or more into their childhood. And so we really want to obviously have earlier diagnosis of children. And if we're doing that, then we can successfully transition them to be adults with narcolepsy. So why is it challenging in particular to diagnose narcolepsy in children? Sometimes the symptoms just look different. Symptoms may include inattention, behavior issues, and mood disturbance. We've heard a lot about the excessive daytime sleepiness, and children have a really high wakefulness drive, particularly early elementary school kids. That's kind of the most awake we are in our whole life. And so they can really present differently. They can mask their sleepiness and look like they have ADHD or mood disorders. And we've talked a lot about that today. If there's misdiagnosis, they can be put on medications that may impact diagnosis. So if you're put on an ADHD medication, that might partially treat your sleepiness as well. And cataplexy can really evolve over time and also can be a little bit more subtle in children. There's something called the cataplectic facies, and children are more likely to have that, where it's a little bit more subtle and it's just involving the muscles of the face. So all of these things can help impact and make the diagnosis of narcolepsy challenging. So what are recommendations for a successful transition from pediatric patients to adult patients? There's very little in the literature to guide us on that transition, and very little specific to narcolepsy. There's some recommendations for general pediatrics. There's a lot about kids with diabetes or asthma, but very little for narcolepsy. So there is a nice consensus guideline for general healthcare transitions of children to adults. And many of these recommendations are geared toward primary care and are less specific to subspecialists, which obviously we as sleep physicians are. I think an important highlight is an up-to-date medical summary. So having your pediatric provider provide that for your transition to the adult provider is really important. And to discussions about that transition to begin at around age 14, although that actual time to transition may be variable. There are lots of challenges to this, and I'll kind of go through what are the challenges. But in many healthcare systems, geographically, the children's hospital may be separate from the adult hospital. Here at Mayo, we're all integrated together, which is a nice benefit. And we all share the same medical record, but you may be transitioning your child to a provider that may be located across town or maybe in a different medical record, electronic healthcare record. This is kind of a guideline that's set up for us to transition kids from the pediatrician to an adult provider. And it's goes through kind of the age to start talking about it in early adolescence, and then ultimately transition anywhere between 18 and 23 years of age. Many times if a child is going through college, we follow them through college. There could be other kind of nice breakpoints where you make that transition. It's not really set in stone. But again, this is around the time when many individuals with narcolepsy are actually being first diagnosed with narcolepsy. So having that discussion to transition them for another provider, I think, is really hard when you're just making the diagnosis and getting them set up on medications. Oops. We also have a lot of factors involved in this transition. Obviously, the patient is at the center of this, but obviously your provider is another portion of this, and then parents and caregivers are involved. There can be variable care plans that are involved. Obviously, the medications are a huge part of this transition. Knowing what you've been on before, what's worked for you, what's not, what's working now is really important to pass between providers. And then as your child gets older, giving them more autonomy over their health care is going to be variable and really specific to your child and where they are and developmentally, where they are with their illness, and probably how fresh and new the diagnosis is as well. So again, there's a lot of changes happening during that time that make this transition difficult. And then Transitioning from high school to college, it can be a big transition, and the school may be involved in different degrees. So in terms of managing medicine, many children with narcolepsy are going to have their medication managed by the parents. And we want to transition that medication over a number of years to the child. And again, when they're ready to do that and when they're not ready to do that is quite variable. And we don't have recommendations for stimulants in children or some of the other medications. There are some recommendations, showing that children around age 12 can start to manage their medication with oversight. But most of that literature is in diseases such as asthma, which is a very different class of medications with very different impact than narcolepsy. One of the, helpful things is that I think that it's probably pretty obvious if the medications aren't going well in narcolepsy, where some other diseases, it can be a little bit more subtle. And then the school likely has rules and often keeps control at school of the medication administration. And so again, when you're done with high school and you're no longer having a school involved and having that structure, that can be a time of change and transition. So some specific challenges in general, just to the treatment of pediatric narcolepsy to touch on, FDA approval for medication can be quite variable. For example, modafinil is approved in 16 and older. Sodium oxybate is approved in 7 and older. And many medications have variable FDA approval. We're used to this in children. It's not uncommon for us to use medications that are not FDA approved, but insurance can be a significant barrier in keeping us from prescribing the medication that we actually want to treat your child. There have been some recent medication shortages, like with Adderall, that can be a challenge. And certain medication administration can really impact the whole family, such as sodium oxybate given twice nightly with a young child is going to need parent involvement often for that administration. And then treatment includes controlled substances, which is, a full-time job to keep track of refills and making sure that you're contacting your provider for the monthly medication refill. That time of transition for the parent and caregiver and child is also a time of life transition, right? So when you're transitioning from high school to college or high school to your first job, there's a lot of changes in general. So again, transitioning your healthcare provider that maybe you've been with for a long time may not be ideal. And it is a time where things can slip through the cracks. So having a transition plan is very important. And then the electronic medical record also makes that transition challenging with variable access to your child's medical record. You're having full access, but once they become a teenager, your access is limited. And then after 18 years old, your child is really going to be in charge of their own medical record and communicating with the family. So there's more autonomy, and in addition to needing to be autonomous in administrating medicines, they're going to have maybe more autonomy over their sleep schedule or, when they're going to take classes or their job, which may cause more variability in sleep schedules. They may move further away from their provider. So they may move to a college that's in a different state from their provider, and that might provide more challenges for follow-up. And as we mentioned, I'm sure you guys know, medication refills can be time consuming. And then there's the exploration of potential careers. So setting your child up for success, I want to discuss 504 plans. I strongly recommend Wake Up Narcolepsy strongly recommends 504 plans for all patients for narcolepsy. I'm definitely not a 504 plan or IEP expert, but I frequently write letters for my patients and recommend 504 plans. And what this does is it makes teachers in school aware of the diagnosis. It allows for some testing and school accommodations, and it can allow students to prioritize sleep. So all of those things are really important. It's a federal civil rights statute, this is for any disability that affects a major life activity, including sleeping, and it gives accommodations. An IEP is a little bit different. Often children have to be kind of behind in school, and it comes with federal funding, and it often includes modifications and accommodations, but some children may benefit from one or the other or both. This is a letter, I'm sorry, it's cut off a little bit, that I often write. In the first paragraph, I'm highlighting kind of what narcolepsy is and what some main symptoms are, and then some accommodations that I often recommend. I'm always looking for input and feedback on these accommodations because I think, again, this isn't exhaustive and it may not be the only accommodations that are needed, but it's a good place to start and start that discussion with your school. Wake Up Narcolepsy has some great resources, and I saw that there was a letter in one of their webinars from a different institution that also included some of these accommodations, which I think are great to be helpful as well, like the 1 to 2 study periods during the day, allowing the student to get more work done when their medications are active, scheduling gym class in the afternoon. So classes can be in the morning when they are more awake. And obviously we don't want any sort of activity or sport restrictions for narcolepsy because being active is really helpful to promote healthy living. I just want to say that, you as a parent, you're living this, and thank you. I know that advocating for your child is also a full-time job and takes a lot of energy, and what you're doing is amazing. And learning to advocate for yourself as an adult with narcolepsy is also really important. So I see you, and I know that this is really, really important and really hard. So this is a challenging time transitioning to adulthood, but a great opportunity to set your child up for success with narcolepsy. Here, again, like I said, Wake Up Narcolepsy has great resources on their website regarding this. If you live in Minnesota, the PACER organization is a great organization if you're dealing with IEPs or 504 plans for your child. And I guess we're taking questions at the end.
Great. Okay. Well, thank you so much. It's really a pleasure to be here to discuss pregnancy and parenting with narcolepsy. And before we get going, if anyone needs to yawn, stretch, stand up, whatever, do it. You are welcome to. So let's get going. So I thought we would discuss some common concerns that come up in the process of family planning while living with narcolepsy, and then some potential suggestions to consider. So I think the most important thing, and it's been said multiple times, including by our panel earlier, that having a good, open, and trusting relationship with your sleep doctor is so important throughout the process. It's a lifelong disease, and we want to be here for you through every step of it. And I think from the very beginning, at the time we make the diagnosis of narcolepsy, the discussion should be not only this is the disease, here are some potential treatment options, but also to help chart out what the future course looks like in terms of school, career planning, and family planning. And the shared decision-making strategy, I think, works best, where you, the person living with narcolepsy, is at the center. Sometimes having a loved one or a partner be there can be helpful too, to serve as your advocate and just a second pair of ears. The sleep doctor, and as we'll talk through some of the questions that come up through pregnancy and parenting, sometimes bringing in other specialists can be helpful too. So we'll start with discussing preconception, pregnancy, breastfeeding, but then we'll talk about some early parenting strategies, and those apply to people who are starting their families through adoption and dads with narcolepsy as well. So we'll start with that preconception stage. When a young woman tells me that they're thinking about starting a family, we know that that process of trying in some people is immediate, and then in other people it can last for years. And sometimes we will make the decision together to stop medications for narcolepsy when trying to become pregnant. And so again, that has to be based in good discussions and shared decision-making. But if that's the plan, sometimes meeting with a fertility specialist can be helpful. These are specialists that can help define a plan to get you pregnant as quickly as possible so there's less time off of medications for narcolepsy. Some of my female patients have also had success using ovulation strips. These predict the most likely times you'll become pregnant. And so the way they use them is when they're ovulating, they'll stop their birth control, they'll stop their medications for narcolepsy and stay off until pregnancy is confirmed, Or if they get their next cycle, they go back on their birth control, back on their narcolepsy medications. Again, it's another strategy that can reduce the length of time you're off of your medications. And really the only form of birth control that you can do that on-off cycling is with barrier birth control. And just as a reminder, some narcolepsy medications, namely modafinil and armodafinil, can reduce the efficacy of oral contraceptives. So important to know. So with pregnancy, the goals are healthy you and healthy baby. And so some questions that come up that you might want to think through or discuss with your healthcare provider are, what are the risks of my narcolepsy medications with pregnancy? Are there alternative drugs that might be safer? What would my symptoms of narcolepsy look like if I stop my medications? And could those symptoms potentially lead to risks during pregnancy? Some of my patients also ask me, does having narcolepsy increase my risk of pregnancy-related complications? We definitely need more research here to guide us, but overall, it does not look like having narcolepsy imparts a significantly increased risk for pregnancy-related complications, and it's very rare for cataplexy to pose problems during the delivery and birthing process. So now let's talk about some of the classes of drugs and potential risks during pregnancy and breastfeeding. So modafinil and armodafinil are classified as class D, where there is at least some evidence of risk when used during pregnancy. And so there's birth registry data that shows that there's at least a small risk of congenital malformations, including heart defects, in babies born to women who are taking these medications. It's not understood if these drugs pass into breast milk or if that could cause any risk to the infants. For methylphenidate, there's inconclusive evidence to know if these could present with fetal risk. There is some reports of premature delivery in low birth weight infants, and we really don't know if methylphenidate has any impact on breastfeeding or if that could pose any risks to the baby. Also for oxybate, there's really inconclusive evidence to determine if there's fetal risk. We know that these drugs pass across the placenta, they pass into breast milk, but we don't know if these result in any risks to the infants. So determining to enter pregnancy on or off meds is a very individualized and personal decision, and it really requires a good discussion of the risks on both sides, being on the medications or the risks of the narcolepsy symptoms if you stop them. And again, shared decision-making. And this might be a time where we will consult with the obstetrician or sometimes even go to a maternal fetal medicine specialist. These are obstetricians that have specific training in higher risk pregnancies, and they can really give great guidance on how to approach this process, especially if the decision is to stay on some of the medications. And pharmacists can be incredibly helpful to look at the medications you're on. Maybe they can suggest an alternative that might be lower risk or a different dosing strategy, or, this drug, really the risks are in the first trimester, but there might be lower risks in the second and third trimester. So bringing all of these expert opinions together to determine the safest plan moving forward is really important. And then if the decision is to not take medicines, or even if it is to stay on medicines, there are plenty of ways to optimize alertness without drugs. And we have, I think, talked several times about the importance of scheduled naps. I cannot overstate that. 10 to 15 minutes, maybe even up to 20-minute naps, appropriately timed so they cover you during those periods during the day where you're most sleepy, can be incredibly helpful. One nap can often buy you a couple of hours of increased alertness. Exercise is incredibly important too, as long as the OB and other healthcare providers feel that it's safe for you. 20 to 30 minutes is a great target. It can be split up into short segments. It doesn't have to be, huffing and puffing on a treadmill. It can be things like walking or yoga. Choose something that feels good in your body, and that exercise will really enhance alertness. Morning sunlight, I think we've mentioned that a couple of times too. It really revs up those neurotransmitters of alertness and can really help getting out of bed and starting the day. And then finally, ask for help. I think I'm so fortunate to take care of many patients with narcolepsy, and These are some of the strongest individuals I have ever met. And I think part of that is because there is, these are folks that have had to work twice as hard as everyone else to just push through that intense sleepiness on their shoulders. And so asking for help doesn't always come naturally, but this is a time where it's really necessary. And then taking care of yourself too. If baby's taking a nap, you should take a nap, even if there's a pile of laundry on the floor. Good nutrition, eat high density, good nutrition foods. That will give you sustained alertness throughout the day. And getting help. Maybe have somebody else clean your house. Ask somebody else to take care of baby for a couple of hours so you can grab a nap. Choose, services that help you with meal prep, or find things that are just really easy to make, but also provide good nutrition. And then again, looking at, do I breastfeed? Do I formula feed? That's another step that just really requires good, careful discussion and decision-making. If the plan is to breastfeed, again, discussing the medications you're on and if those might present risks to the baby. And working with a lactation consultant if you're breastfeeding can be really helpful. Some babies like to nurse for like a little bit, sleep a little bit more nursing, a little more sleeping, and nighttime feedings can last forever. A lactation consultant can really give some pointers on how to make feedings as efficient as possible. So baby goes back to bed, you can go back to bed and get some more sleep. And then there's multiple safety considerations. Driving is probably the biggest one, especially if you've come off of your medications. Never get behind the wheel if you're not fully alert. There's Uber, there's Lyft, they're so cost effective now. Ask a friend to drive you, but don't get behind the wheel if you're sleepy. Cataplexy is another challenge to discuss. Cataplexy can potentially present risks during pregnancy if you lose postural tone and you fall. Could also present a risk if you could potentially drop baby. So it's something to think through. This is a case where sometimes I'll counsel my patients, well, maybe we should be on a small dose of an antidepressant from a safety perspective, or we can figure out behavioral strategies to really limit the risks of cataplexy, making sure you have places you could easily, safely put the baby down. Feedings, that's another thing. Specialty pillows are out there that sort of keep the baby in a safe position so that if you fall asleep while feeding your baby, the baby stays safe. And then finally, doing a mental health check-in is so important. This is stressful for anybody. Then you add on the challenges of having narcolepsy on top. We know that increased stress, changes in medication, less sleep, all of those can exacerbate symptoms of anxiety and depression. Bring those up to your provider so that we can all come together and formulate a good treatment plan. And then finally, support. And that support can be through many different ways, from a partner, other loved ones, neighbors. The people that know you want to help you, so ask for it. And then Wake Up Narcolepsy has great resources for support, and I think Emily's going to be talking about those in the next talk. Thank you so much for your time.
I realized just now I don't have a slideshow, but I should have put up some pictures of my cute kids. But you might see them running around here. Hi, I'm Emily, and I'm the mom of two boys, Damien, who's 3.5, and Miles, who's 14 months. My husband, Russell, and I have been together for 11 years. And as it was mentioned, we live in Seattle, Washington. While I don't currently live in Minnesota, this is where I spent the first 18 years of my life. So coming out to speak to you is also a bonus trip to visit my family. I was diagnosed with narcolepsy type 2 in spring of 2009 when I was a sophomore in college, roughly 2 years after the start of my symptoms. I'm here to talk about how it's possible to be pregnant and a parent while managing narcolepsy. I always knew that I wanted to be a parent, but what I didn't know was how severe my symptoms would be once I was pregnant. After my first positive pregnancy test, I went off all my medications. Russell and I made the decision because of the lack of research there was regarding Xyrem's impact on the fetus. Going off Xyrem meant all of my symptoms returned. Insomnia lasted for hours every night, which meant during the day, I was often battling the excessive daytime sleepiness. When I laid down to nap, I was haunted by hallucinations and delusions, often unable to fully awake from the terror as the sleep paralysis trapped me. I was thankful that I didn't have to go to work every day. Instead, I could rest when I needed to and focus on just managing my symptoms and growing the baby inside. My second pregnancy, however, was completely different. Now I had a 1.5-year-old that was in my care 24/7. If you don't know this already, let me tell you a little secret. Toddlers don't sit still, and they require your undivided attention. Since I needed to be awake and present for Damien, I decided to stay on Concerta, but go off Xyrem. That first trimester was rough. Every day I was counting down the minutes until Damien would take his afternoon nap so that I could nap too. And in the late afternoons, I was often begging Russell to end work early so that I could rest again. But I kept pushing through. Going into the second trimester, I was hopeful that the extreme sleepiness would fade a little, as it did with my first pregnancy. But it didn't. I was miserable every day because of how sleepy I was. My mental health started to be impacted because of how tired I felt. I never felt like I had enough energy or patience to care for Damien. The mom guilt and the depression hit me really hard. I talked with Russell, my OB, and my sleep doctor about going back on Xyrem. Everyone agreed that my mental health was an important factor in having a healthy pregnancy. And if I needed to get more restful sleep in order to improve my mood, then Xyrem was the best option. I met with a high-risk OBGYN for my 20-week ultrasound. This doctor had worked with other patients who had stayed on Xyrem during pregnancy. We discussed the risks and benefits, as well as the known and unknown things that may happen to the fetus if I went back on it. The ultrasound showed that the baby was growing well, and the OB didn't have any concerns with me going back on it. So I started taking Xyrem again, at a lower dose just to be cautious, but still therapeutic dose. And it was the best decision I could have made for myself. I continued taking it up until giving birth to my second boy, Miles. With both babies, breastfeeding was something that I really wanted to do and was a priority for me. I thought that delivering a baby was going to be the hardest thing I was going to have to do, but I quickly learned that breastfeeding was much harder than other people made it look. Not only do newborns eat for long periods of time, they also want to eat every couple of hours. Our first night home from the hospital, I remember crying at 2 a.m. because Russell had woken me to feed Damien, and I didn't want to get out of bed. I just wanted to sleep. He ended up giving Damien formula so that I could go back to sleep, which at the time I thought was the end of the world, not the formula. When I look back now, I laugh at just how ridiculous that was. Formula or breast milk, it doesn't matter. A fed baby is a happy baby. So before having Miles, I made sure we had a little formula on hand in case I was unable to get up and feed him at night. After a couple of weeks of being unmedicated with both of the boys, I knew I needed to get back on Xyrem. With my first, I wasn't as urgent to do it because I was able to take naps whenever Damien was sleeping. But with my second, Miles, sleeping whenever I wanted was not possible. I had a toddler who needed me to be present for him. So we created a plan so I could get back on. This is where I'd like to thank Wake Up Narcolepsy for starting the support groups. Back in 2019, when I saw a social media post about the pregnancy and parenting narcolepsy support group. I knew I needed to participate. I was hopeful that I'd be able to connect with other pregnant individuals with narcolepsy and get some helpful information. What I have gained from that support group over the last 4 years is not only incredible information, but I have met some of the kindest and strongest people. This group is not only where I've gained a wealth of knowledge, but I have been able to share my experience and knowledge with others. Because of this support group, I was able to hear from others who stayed on Xyrem while pregnant and learned more about breastfeeding and taking Xyrem. Around the time Miles was 1 month old, I went back on Xyrem. I started by taking 1 dose at night. That 1 dose made a huge difference in my sleepiness and my mood. Russell was in charge of feeding Miles during the 4 to 5 hours that I was asleep, and then I would take over for the remainder of the night. We did this system until about 5 months old when Miles started sleeping regularly through the night. Then I went back to my regular 2 doses. For this all to work, Russell has played a big role. He is the one that consoles the boys in the middle of the night if they wake up crying. He is the one that helps me make sure I'm taking my meds on time and sticking to my schedule. I couldn't ask for a better partner. When I told him 11 years ago that one day he would have to be the one getting up with the kids in the night, he didn't even question what I was asking him. Now, he might be grumpy from time to time when he has to get up out of bed in the middle of the night, but aren't we all? In order to manage my symptoms and be present for my family, self-care is so incredibly important. I will tell you, though, that this is one of the hardest things that I struggle with. As a stay-at-home mom, my mind is always focused on the boys, the house, and making sure everything and everyone is running smoothly. I am not someone who regularly takes naps. If I stick to my sleep schedule, take my meds at the right time, and don't eat too many carbs and junk food, the EDS is very minimal. But what I do need is time to myself. Even just 15 minutes to sit in silence or lay down and close my eyes. My 3.5-year-old doesn't consistently nap, so while the youngest is sleeping, I still have the oldest awake. So I push those articles aside, the ones that say too much screen time. I hand Damien a snack and put Bluey on TV. This allows me the space to recharge. I used to put the TV on and then run around the house trying to clean up and getting chores done, which sometimes I still do. But more recently, I've been taking some time to recharge. This helps me get through the most challenging parts of every day. That time right before dinner and bedtime. Another helpful tip I've used when I've needed to rest is putting Miles in a safe place and setting Damien up with a quiet activity. For Miles, this safe place is his crib. I'll put him in there with books, the light turned on and the door opened. Occasionally he will cry, but oftentimes he just hangs out looking at books until I get him. This gives me 10 to 15 minutes to lay down and rest. When there are multiple days of feeling overwhelmed or exhausted, I have a couple of friends I can ask for help. These are friends that I've met since becoming a mom. We all help each other out. I'll watch their kid or kids for a couple of hours, and then when I need help, they'll watch the boys. These people are part of my village, and I'm so thankful to have them. For those of you that are thinking of becoming a parent, I encourage you to talk to your doctors ahead of time. Find a team of doctors that'll support you on your journey. I realize that I live in a city where I have access to many doctors. Not all of you have the option to bounce from one doctor to another until you find someone who will support you with medications during pregnancy. When I told my OB about wanting to go back on Xyrem, the first thing she told me was, I don't know a lot about your condition or medications, but I will refer you to someone who does. Asking for a referral is another great option that could be beneficial. So here I am, a tired but functioning mom with narcolepsy. These last 4 years have not been easy, but they've been completely worth it. Thank you for allowing me this time to share my journey. I look forward to answering any questions and supporting others on their parenting journey.
is a question for Emily, but also kind of for the doctors to chime in as well. Emily, I know you said that in your first pregnancy, you were not working. And I was wondering if you were out on disability, and if the doctors could kind of confirm if, and many of their patients do that too.
So I was, before having kids, I was a nanny and my contract had ended and then we found out I was pregnant. So I kind of just didn't go with another family because I didn't know how I was going to act or how my symptoms were going to be being off of my medications. And so we just budgeted really well. Thankfully, we are able to do that and I didn't have to keep working.
I can try to answer to that. It's a great question. And yes, if in some of my patients who, especially if they've decided to come off of their medications during pregnancy, the symptoms are so severe, work is just not possible. And so absolutely in those cases, we've written letters and sometimes an appeal letters and so forth to try to request disability during pregnancy.
Hi, I was wanting to find out if there's any studies or research or maybe issues for males on the Xyrem, Xywav, the Adderall. I'm trying to think of all the medicine our son's on. Venlafaxifenes at max doses for any fertility issues to start, thinking about that could present problems.
That's a great question. And there's, I would say, very, very little literature, very little research. I mean, these are areas that are really tough to do ethical research. And so a lot of times we're using retrospective data, looking at registries where women have entered a registry and, that we're looking at outcomes and then looking at, okay, what medications were they on? But they're really hard to pull. You can see associations between a drug and an outcome, but it doesn't mean causality. And, sometimes these registries have people that maybe haven't had other prenatal care access. And so it's really, really hard to pin certain outcomes on certain drugs. And in terms of fertility, I think there's unknowns there. We just don't know. And so I think that's just the most honest answer I can give you. I wish we had more information. Narcolepsy is a disease that affects young people who are at a time in their lives where they are thinking about starting a family, and there's very limited information, but we try to do the best with what we can. And just like Emily had said, it's possible to be successful and be a successful parent with narcolepsy.
I've talked to a lot of women who are in the parenting and pregnancy online support group, but I've never really listened in on the conversation. So is it possible for a person with narcolepsy type 1 who's on maybe 3 medications to get pregnant and continue working, kind of do it all?
We have quite a few of the women that are in the support group are still on medications and are still working. I'm very impressed by them.
That's
I mean,
encouraging.
that's kind of how when I first joined the group, the leaders didn't know anyone that stayed on Xyrem. I didn't know anyone. No one in the group did. And then all of a sudden, like 2 years ago, we got a bunch, like an influx of women, and they're like, yes, I stayed on Xyrem. And that's why when we started talking about getting pregnant again, I was like, wait, all these people stayed on Xyrem? Like I wanted that because that's what helps me function. So.
Great. 2 questions from online. Any other questions? Thank you, doctors and Emily.